está comenzando. Todos los asistentes están en modo de solo escucha.
Hello everyone, welcome back again with another InMode webinar in this period of pandemia. I'm Dr. Ignacio Genol, I'm from Madrid. I'm a board certified ophthalmologist, but I've been specialized in periocular surgery and periocular diseases, lately mainly focused in aesthetics, in periocular aesthetics. I'm going to talk about the Accutide Morpheus bipolar radiofrequency and the treatment of the periocular aging. It's going to be like a 30-40 minutes talk, and we have after that a period of questions from the audience. Waiting. Thanks to the InMode company for giving me the opportunity to be here with all of you during this lockdown. I hope you are all doing well. I'm going to start with this slide talking what are we going to discuss during this lecture. We're going to talk about what's Accutide, what's Morpheus, and the technique that I used to perform this particular area. And we'll give a few tips and a few tips about the technique, but we're going to focus about the anatomy and the clinical findings in the periocular area, and finally we're going to go deeply into the patient selection. What are the most ideal candidates for this treatment with this technology? Okay, so when we're talking about the Accutide is the smallest handpiece of the BodyTite platform, and this it used to be called like injectable radiofrequency, because you have two arms in a handpiece. One is over the skin and the other one is under the skin, and the length of the under skin arm is like 6 centimeters. It's more or less like a blunt tip cannula that we used to treat our patients with hyaluronic acid or some other fillers. And when we are using Accutide, I'm going to show you what's happening. When you push the pedal, then there's a, sorry, move this around. Oh, so I cannot do that. Okay, so there's an external pole with positive pole, and there's an internal pole where the radiofrequency flow comes from, and it goes from the inside out, and there's a heating of the tissues between both arms. Okay, and that heating will give you the improvement of the tissues, because you will find that after the application you will find immediately a denaturation of the lower reticular dermis, and a coagulation of the fibroceptal network, and a coagulation of the immediate subdermal fat. But after a while, like 6-8 weeks, something a little bit more sometimes, you will achieve a thickening of the dermis and superficial fat remodeling, and a new dermis will arise. So you can achieve this kind of results without surgery. It's called non-surgery blepharoplasty. That's okay, but I'm going to give you my point of view about this kind of result in this kind of patient. When you are not familiar with treating this kind of areas, if you are starting to treat these areas, I'm going to give you my point of view. But first of all, I'm going to give a small, we're going to talk about some specifications of the handpiece, but they are not that very important. But it's important to know that this the power is automatically adjustment. There's up to 16 BTOs, and when you use it, you need to establish, you need to go to the device and then decide which temperature you want to achieve internally and externally. And after that, you don't need, once you have done the procedure, you don't need to remove the liquid, or there's no need for aspiration. Okay, but I don't want to go very deeply about how to perform this treatment, because most of the people are, most of the audience already has this treatment and already have performed treatments with the Accutide and already know what this handpiece, how this handpiece works. Okay, there's an electrode, there's a cannula tip with a plastic protector in order to avoid accidental skin perforation. That the heating comes from the inside pole, that you can see here, the internal electrode, and it goes up. It's like an inside-out flowing of the heating. Okay, well, I'm going to show you some Accutide settings in periocular area. I do not used to do it frequently because settings are risky business, in my opinion, because it depends very much on the experience you have, on the characteristics of every single patient. But for those who are not very familiar or are starting with the technology, I want to show you some settings that could be standard for periocular area. For example, if you are working in the upper or lower eyelid with Accutides, I would look for a external cut-off temperature like 40 degrees. And if you're trying to achieve like 70 degrees in the internal electrode. More or less, I would say that the total amount of energy delivered in every single eyelid will be around between 6 and 9 kilojoules, okay? That could be a standard setting. Because when I'm going to show you this video, hopefully you can see it properly, but in this video I'll show you the end of the procedure that sometimes used to be forgiven, or because this is a retrograde fashion after the treatment. This is the end of the treatment, okay? Once you have done the treatment, you know, when you move the handpiece back and forth several times and then you have achieved the degrees that you were looking for, at the end, I used to go with a single pass at the end, all right? And so many times I used to combine the Accutide bipolar frequency with Morpheus and with autologous fat transfer. And I'm going to show you here in the lower upper and the lower eyelids how sometimes we use the Morpheus. It is here, you know, this device. I'm going to talk about it a little bit later. And when we use fat transfer here at the end, we use the Morpheus to improve the quality of skin in the late of the surgical procedure, of the technique. You can do it at your own clinic with the surgery theater as well. So when we're talking about the devices, of course, there's some hand pieces that goes inside and outside with the arms. There's Accutide, FaceTite, or BodyTite, and the Morpheus is the only one device that's only placed over the skin, and there's a tip with a 24 pin that are silicone coated that goes into the dermis, and then at the end it's something like this, okay? The tips are these ones, and when you push the pedal, then the radio frequency comes out at the same philosophy as the Accutide, all right? And then achieve like a result like 6 weeks later, the same result more or less, but only in the first 4 millimeters from the skin. You can only go to the depth of 4 millimeters using Morpheus. But it's very important to use it in several planes, not to use the Morpheus only in a single plane, for you to achieve an even result, not with the irregularities or lumps or something. So these are the settings that I used to perform in a periocular area. I used to go with 2 passes of 3 millimeters, then 2 passes at 2 millimeters, and with an overlapping between them between 35 and 50%, and with an energy around 35 BTUs. But this is something that you can adjust depending on the characteristics of the patient. You can go to 2 passes at 4 millimeters, then 3, then 2 millimeters. You can overlap 30%. You can go for an energy around 40, 45, depends. But for the starting procedure, and if you're not very familiar with the treatment, that could be a good option. And once you see the result, then you can adjust what you're looking for or what you can change. Okay, I want to show you some in-mode partners physician results, because once you are very experienced, like Dr. Mulholland here from Canada, who is the inventor of the device and one of the most experienced surgeons in the world using Accutite around the eyes, you can see a very nice result with this retraction of the fat pads and the quality of the skin, and I've seen very awesome results here. But as you can see here, and these results are without surgery. That's okay. Can't believe that, of course. But I want to give you my point of view in this particular area, in the particular area. When there's an area where you can find so many times disappointing results in the periocular area, and this could be due to these 4 factors in my humble opinion. This could be because of the physician expectations. Once you see Dr. Mulholland results, you may think that you can achieve that results, and that's something that I'm not really sure that you can do it, because you need an experience and a learning curve. Okay, sometimes the disappointing result is because the patient are very high expectations, and that's our problem. We should notice that the patient had a very high expectation in advance, and sometimes it's because physician technique is not the proper technique. I don't think so. You have bought the device, you have been through a training procedure trying to get the maximum of the device, and so you all know, you have your learning curve, okay, but you more or less all know how to perform these treatments. But in my opinion, the most important thing when you find a disappointing result is because you haven't selected a good candidate to be treated. So it's not an issue of the device doesn't work, or it's not an issue that you were expecting so much, or it's not an issue. I think, in my opinion, the problem is that you haven't selected a good patient. And this is what I'm going to talk about deeply in this talk, because once you select a good patient, the chance for you to get a good result are much more higher. So for that, I need to talk about a few slides about anatomy. When you see anatomy of the eyelids, it's very important to know, because you have to know where to place the inside arm of the handpiece. Okay, if you have the skin here, if you remove the skin of the periocular area, then you'll find the orbicularis muscle. Here, the orbicularis muscle is divided in areas, but we're going to talk about later. And if you remove the orbicularis muscle, under that you will find the the orbital septum. This is very important structure, okay, because divide the intraorbital and the extraorbital space. And it's very important to know this structure, because it retains the fat pads in the inner side of the orbit. So if you open up the septum, then you'll find the fat pads that are all around the eye, okay? And between the central and the internal fat pads of the lower eyelids, you'll find the obliquus inferior muscle that is very important for you not to damage in order to avoid diplopia. So when you're treating the periocular area, if you're looking for an aggressive treatment and you want a very important retraction of the fat pads, you take care of that, because the inferior oblique muscle is between both fat pads, and need to be careful with that. And in terms of vascularization, there are not very important structures to be damaged, but be careful in the area of the medial canthal tendon, because there's an angular vein there, and there's a drainage system around there, and the heating with the Accutide could damage these structures. We don't want to. In terms of nerves, there are only 3 areas that should be careful, but if you are working in the plane that we're going to talk about later, you shouldn't damage these structures that are very deep and close to the bone. So you have here in the upper area, you have the supraorbital and supratrochlear artery vessel bundles and the infraorbital nerve. You're not going to touch these foramens because you're working in an upper plane, much more closer to the skin. Okay, so in this sagittal view, you can see here that's this is the bone, and this is the, can you see this point? There's a red point here. This is where the tarsal plate begins. Okay, so here this is where the supratarsal fold starts. So when you work with the Accutide device, you are working in this area, and you can work under the skin or under the muscle, depending on the characteristics of the patient. Okay, but shouldn't go behind this line, that's the septum. So if we're talking about in lower eyelid, when you have a fat pad prolapse, okay, the fat pad comes from the internal aspect of the orbit and comes outside, and there's an orbit. This blue line is like the orbital septum, as we said, okay, and this is the orbital rim, as we used to call it, arcus marginalis. Sometimes when if you're trying to retract the fat pads, you cannot work only in the skin or in the muscle. You need to perforate, you need to make a hole in the septum and then introduce the inner arm of the handpiece into the fat pads, but you shouldn't go further away or deeper than the orbital rim from the arcus marginalis because of the reason of the oblique muscle. Okay, that's my opinion. So when you're treating upper eyelids, you need to study some things that gives you keys or information for you to know if it's a good patient to be treated or not. For example, the position of the brows, if there any excess of skin, is there any excess of fat, or is there any asymmetry or an eyelid ptosis. So if you see this patient, for example, it's a single, it's a skin excess without any other findings. It's a good candidate because it has a good position of the brows, and there's a mild excess of skin, as could be this female patient that you can see here. Okay, but sometimes you can start treating this patient. You better start treating this patient and do it over the supratarsal fold. Okay, from here to the brows. This area is the area that we should treat. But sometimes this, you can find patients like this with a fatty upper eyelids where the brows are very low and there's a heavy lids, and you will not achieve a good result if you are trying to rise the brows or the lids using a bipolar frequency, because it's very hard to achieve a very good result even with surgery because of the heavy structures of the tissues. Okay, you cannot expect very good result in this kind of patients, or for example this patient with the heavy eyelids and even have a eyelid ptosis. If you find this kind of patients, you better send the patient to an oculoplastic surgeon or for a plastic surgeon who is familiar with the eyelid surgery. You will avoid problems here. Or this kind of patients with a roof hypertrophy. The roof hypertrophy is finding that this because of the hypertrophy of the retroorbicularis oculi fat that is under the brows, but it's over the septum. It's not behind the septum. And you can treat these patients, okay? You can do it. But when you use Accutide in this roof hypertrophy, if you want a shrinkage and you're looking for the contraction of the fat that is under the brow, you need to look for a very important internal rise of temperature, even 70 or and deliver much more than 6-9 kilojoules per eyelid. You need to go to 10, 12 in this area. And if you go to that point, then you're going to have an important edema and the recovery will not be that good. So for you you need to decide if you want to treat it or not, but it's not the ideal candidate, in my opinion. Or, for example, this patient with right upper eyelid ptosis, this is her upper right eyelid. You can see here there's a very important difference between both eyelids, and this you cannot expect to raise the eyelid only with Morpheus or only with Accutide, because it's very difficult to fight against gravity, and the tendency of the eyelid is always to go downwards. And if you're trying to shrink soft tissues only with Accutide or with Morpheus, the rising will be soft, and it's very difficult to achieve a very good symmetry and a result that gives satisfaction to our patients. Or, for example, this patient where you can see has a mild skin excess, but there's a very low brow position, as is normal as a young male candidate. If you're trying to raise the brows with the Accutide or the Morpheus, it's going to be tough. So I do not recommend you to start with this kind of patients, because the results will be very, very, very moderate. Or okay, and sometimes it's not that common, but sometimes you can find it. Some people has a very important or prominent orbital superior orbital rim, and gives you the appearance of a deep set eyes. We used to call it enophthalmos. Okay, you can treat this patient. Of course you can do it, but be sure that the patient has the good expectations, because there are not so many skin or orbicularis muscle to be contracted. So you will achieve a soft result here. You can do it, okay, but there's not the ideal candidate. And for example, this last one, the mild asymmetries between both eyelids are very, very difficult to be treated, even for surgeries, because there's there's something that's a very millimetric differences between both eyelids, and you can treat the upper left eyelid. I mean, this is her left eyelid. You can treat this, or you can treat this in order to get an asymmetry. That's okay, but it's millimetric, and be sure that the patient doesn't want a perfect symmetry in this kind of patients. So what would be in my opinion, the best candidates to start with treating with Accutide and Morpheus in the upper eyelids? Patients with a good brow position, the higher the better, and with a mild excess of skin, and with no asymmetries, with no eyelid ptosis, and mild fatty eyelids, or no fatty eyelids, for example, like this. This could be a good candidate with a good brow position and with a mild skin excess, and there's not so many fat in there. There's a good symmetry between both upper eyelids. That's a good candidate, okay? Or this patient, for example, as well. So in talking about lower eyelid, in my opinion, it's a little bit it's more complex to be treated, in my opinion. And you need to look for, you need to assess very carefully these findings. Is there any excess of skin? Is there any excess of fat in the lower eyelids? Is there any retraction? Can you see any scleral showing there? And how deep is the tear trough and the extension? And to assess, and in the end, it's very important to assess the laxity of the medial and the lateral canthal tendon. And this could be the most important take-home message of the lecture. That is that most of you're familiar with the device, and you know how to treat patients using Accutide. But the periocular area, I think that is a particular area that is quite difficult to achieve a very, very good result. In my opinion, eyelids are for advanced level physician in terms of that you have been through a very long learning curve, and you know these parameters very well, and you have been through a learning and trying to understand which is an ideal candidate or which is a poor candidate. Okay, so we're going to talk about these 5 points, and so it then gives you an idea on which candidates are ideal to be treated with the device. For example, the tear trough. We used to grade the tear trough in three grades. This is grade 1. Okay, this could be grade 2, and this could be grade 3. When you're starting, if you want to try someone with a tear trough, you better start patients with treat patients with grade 1 or 2, but not 3 as this patient. Okay, because there's some other factors in there involved that cannot help us to achieve a good result. For example, who would be a good candidate for this? For example, I could be myself. I have a short tear trough with a grade 1, and there's no very important fat prolapse, and there's not very important skin laxity, so I could be a good candidate for that. Talking about this, the skin excess. Okay, as you can see here, this patient in the right eyelid, you can see here that there's an important skin excess. So this patient will not improve that much if you're using Accutide in this patient. That's not going to improve that much. So look for a better candidate, as this could be this patient like with a mild excess of skin and a thicker skin in here, and that could be a better candidate than the other one. And patients without edema in the periocular area or with mild edema, we'll talk about later, because when you find this kind of patients with very severe edema or with very important edema, first of all, you need to talk with an oculoplastic or ophthalmology, because the most important cause of periocular edema is what we used to call Graves' orbitopathy or thyroid eye disease. Once you have diagnosed, once you know that the patient doesn't have that, then you can start treating with the Accutide. But I would prefer to start treating patients with mild edema. Okay, because the heating of the tissues can shrinkage the soft tissues, and then you can make the water that is around the tissues flows out. And I'll show you some examples. Okay, for example, this patient with this with the orange narrow here and the left lower eyelid with this festoon or malar mound is not a good candidate, in my opinion, to be treated. I would prefer this kind of patients. I hope you can see the pictures properly. And as you can see here, this is mild periocular edema, and you can achieve a good result, for example. Okay. In terms of fat prolapse, I think this is most common patient consultation. How to say it? One of the most common things that you will find in your practice is patients are asking you to improve the fat prolapse. All right, with mild fat prolapses. So you're sure they're working under the orbicularis, between the septum and the orbicularis, and if you want to go a little bit through the septum to achieve a little bit a much better result, that's okay, but work safely, please. This is an example, for example, from Dr. Sean Paul from Texas, Austin, Texas, and you can see here there's a mild fat prolapse. Okay, and if you find this kind of patients with a moderate fat prolapse in the lower eyelids or with much more important fat prolapse, they are not good candidates. They are going to achieve a very important edema after the heating of the eyelids, and the downtime will be long. Okay, so be careful with this kind of patients. You can achieve good results, of course, but it's something that only people with very, very experience can achieve at first. Okay, and to the last point that is important to assess when you're looking for an ideal candidate is the laxity or the retraction of the eyelids. If you can see this patient that I've been talking about before, you can see here in his lower right eyelid, there's a skin excess. That's okay. But much more importantly is that there's a very important difference between the appearance of the right eye and his left eye. It looks like a bigger eye here, and it's due to the retraction of the lower eyelid, because you can see here a wide area between the color of the iris and the free margin of the eyelid. That's what we used to call a scleral show. It's like a 1-2 millimeters scleral show here, and this is due to the retraction of the lower eyelid, probably because there is a proptosis as well, but there's a retraction, and this retraction is always due to laxity, to the laxity of the tissues. And when you are using bipolar radiofrequency, you are fighting against laxity. That's okay, but the limits or what you can achieve using the device is for mild to moderate, but not this kind of patient with very important laxity. And for example, some other kind of patients, for example, patients with what we used to call negative vector. These patients are usually patients with an exophthalmos with proptosis, but we used to call negative vector patients when the cornea is not at the same level of the malar bone. You have the malar, there's no bone support in the malar area, and the tendency of the eyelid and the tendency of the structures of the lower eyelid is due to the gravity to go down. And if you're treating these patients, the heating of the tissues will gives you some tendency to retract the lower eyelid and gives you a much bigger scleral show. So for this patient, you need to be very careful. Imagine that the patient comes to my office and asks me, hey, Dr. General, I want to improve my appearance of the eye. I have this lateral fat pad in the lower eyelid, and I have this internal upper eyelid fat pad. I want you to remove it, please. And I would say, okay, listen to me. I can do that with surgery or without surgery. I can improve it with the Accutide and the Morpheus. But if you remove this fat pad and you remove this fat pad, you need to warn the patient that the appearance of the look after that will be more rounded and will give you a more proptotic look, okay? And the risk of worsening the retraction of the lower eyelid after the heating of the tissues is big. There's a big chance for that, so be careful, okay? So this is our result. Okay, what are we waiting for the future with these technologies? We are starting to treat these conditions, for example, severe festoons. We're starting to combining the Accutide and the Morpheus in a higher settings with very, very high levels of power, but I cannot give you very strong recommendations because we're still studying that. And patients with dark circle are sometimes good candidates to be treated, but this is not a good candidate because there is a very, very dark condition, and there's a very thick skin of the lower eyelid. There's a disease, okay, and needs to be studied by an oculoplastic surgeon and a dermatologist. But sometimes you can find this kind of patients with where this brown appearance of the lower eyelid sometimes is due to the laxity of the tissues. And once you improve the laxity of the tissues, you improve the color of the lower eyelid as well, right? And at the end, I want to talk about the orbicularis hypertrophy that sometimes appears here in the area that is much closer to the lashes line here. Okay, what is an orbicularis hypertrophy? The orbicularis hypertrophy is something that you will see very frequently. And if you take a look to a patient carefully, as you can see here, there's a line with these blue dots here. There's a lower eyelid fold, and there's another line here with the red dot line. This red dot line is what we used to call the T-trough, and the blue dot line is the lower eyelid fold. So between the space of the line of the blue dots and the lashes, this area is the area where the tarsal part of the orbicularis is, and sometimes there's an hypertrophy of this area, and there's so many times the patients wants me to improve that area, but that condition is very tough to be treated with a filler or with a fat transfer, because there is no bone support below the structures, and it's difficult to achieve a good result here. You better start with a botulinum toxin. Okay, you can achieve a good result with a mild risk of retraction, but the result will last like 3-4 months, but no more. And when you're treating with the Accutide of this area, you are hitting the orbicularis and looking for a contraction and a shrinkage of the orbicularis muscle, and then finally improving the appearance of the lower eyelid. This is another example. I'm gonna give you again the dots line reference. Okay, and when you treat in this area, treat the space between the blue dots and the lashes. The area where the red dots is the area that you can treat safely with a filler or with a transfer. Okay, so I hope you have a good idea of what can we achieve with the device. I'm willing to hear your questions, and thank you very much for your attention. Hope you are all doing well. Thank you.
Thank you very much, Dr. Henel, for your lecture, this great lecture. So now we are going to begin with the questions round. The first one came through, and it came from Kurdo Quadrak. When did you see the final result? I guess he meant when you use Morpheus, I guess. I'm not sure. He didn't explain it.
Okay. The question is, when did you see the final result? Okay. More or less, you can. I would say that 80% of the result you will see it in 3 months. Okay, but the improvement will keep on going positively until 6 months. Okay. You need to be patient. It's different from the surgery. In surgery, most of the times in 1-2 months, you can see the 90-95% of the result. Okay, but with the Accutide device, you should wait a little bit more.
All right, thank you. So the next question comes from Mohammed Sabat. What is your procedure to treat the eyebrows?
Okay, my option to treat, if I understood properly, my option to treat brows, isn't it?
That's right. I think he meant, what is your procedure to do your eyebrow lift? I guess, because that's what
I cannot hear you, Javier. I cannot hear you properly, but
you got the microphone?
Yeah,
I hear you.
Can you hear me?
See, better.
Yeah.
Yes.
Okay. Javier, the sound is not good, so if you want, I can start with the questions, okay, for the doctor. So the next question, doctor, is what is your procedure to eyebrows lifting by Accutide?
Okay. You need to be the same philosophy. Okay. Look for a young lady or a young man without a very heavy brows. First of all, that's the most important thing. It doesn't matter the settings. It matters the kind of patient you are selecting. Okay, you need to go for patients with not so many fats and with no heavy tissues, with a not very important, not very low position. Okay, with a mild position, and better young people. With the older people, they have much more laxity, and the answer of the tissues to the heating of the tissue with the Accutide is not that good. Okay, in the browse you can raise the settings like 20% that I have used for eyelids. Okay, so start with 10 to 12, like kilojoules per brow, right? And need to wait as well. Need to wait as well between 3 to 6 months. All right.
Okay.
Okay, perfect.
Thank you, Doctor.
One more question. If the patient has negative vector, can we do fat graft before then Accutide?
Okay, the question is a very interesting question. And the thing is that when you're using fat grafting, most of the time you need to place the fat the deeper you can. The deeper the better, very, very close to the bone and the middle third of the face, and the fat is very, very deep. And when you're using Accutide, you are in a very, very superficial position if you compare it with the fat. Okay, so I wouldn't do it at the same time if you are placing a very important amount of fat, because the fat will be very close to the area where you are placing the Accutide. But if you are doing a soft, if you are not placing a very important amount of fat, you can do it at the same time, and be sure that you are not going below the orbicularis. Okay, you can work in a superficial plane with the Accutide and place the fat. If there's a negative vector or not, it doesn't matter. The thing is, the point is, you are treating at the same time. That's okay, you can do it. The fat will not be the changes that are going to be after the Accutide, because of the heating of the fat that you have placed it before, is not that very important. So you can do it. First the Accutide, and in the end you place the autologous fat transfer, and in the end the Morpheus. That's my choice.
All right, thank you, Dr. Henold. Can you hear me now?
Yes, better.
All right, thank you. So next question is, it comes from Israel. Are there cases that fat removal from eye bags might be combined with Accutide?
Of course, absolutely. There's a thing that we are doing currently, because when you remove the fat bags surgically, and you are removing the fat, only the fat. We used to do it from the inner aspect of the eyelid, from the transconjunctival area, between the space between the eyelid and the eyeball, and you remove the fat from there, and you are not doing any kind of work in the superficial lamines. We used to talk lamellas. That's the skin and the muscle. You are not treating that most of the time. You are just removing the fat and leave that alone. But if you want to give an improvement in the laxity of the structures of the lower eyelid, you need to do a surgical excision of the skin and do an acantoplasty or whatever. But you are doing skin incisions, and then you're doing scars, and all of you know that there could be something noticeable and could be problems. But when you remove the fat from transconjunctivally, and you are giving some tensions to the structures of the skin and the muscle with the Accutide, improving that aspect of the patient, and that's something that we are doing currently. That's a very good point.
All right, thank you very much. Next question. What about associating Accutide with cantopexy to avoid scleral show when you treat fat?
That's the more or less I have said it already. It's more or less the same philosophy as the previous question. You used to, depending on the patient, or the cantoplasties in the proptosis, or patients with a negative vector, are tricky and are not easy to do or to perform in every patient. You need to be a little bit experienced. But combining surgery and Accutide is something that we are working on it, and it's the future for sure. Because if you want, I think that you cannot, with Accutide, you cannot treat every patient. This is my point. But sometimes you can complement, or you can give an extra point to our surgery without performing any kind of skin incisions, no?
Right. Okay, thank you very much. Next question. Do you use Accutide and threads together for brow lift?
You can do it. You can do it. It's not my common practice, but you can do it. I have attend to a lecture of Dr. Mulholland, or if I don't remember, if I remember well, talking about this. Okay, I'm not familiar with the technique. I'm not very experienced using threads, but you can do it. You can do it. I've read it, and I'm not the best one to ask about threads, but I know that you can do it.
Excellent. Thank you very much. One more question. Can you elevate the eyebrow with Accutide? Well, yeah.
Of course, you can raise the position of the brows with Accutide, but the most important thing, one more time, is you look for a good brow to be raised. Okay, don't look for a brow like me. For example, look at me. I have a flat brow. I have a very low brow position. Okay, and as I'm a male, I have a very fatty brow and heavy brow. If you're trying to raise my brows only with Accutide, it's going to be tough. Okay, you need to look for someone with a higher position of the brow, with intermediate fatty brows, and I would start with a female. Okay, I would start with a female because it's more frequently to find a female without that heavy structures in the brows. And I think you shouldn't forget that you're fighting against gravity, and the gravity always trying to give you down, the pulling down all the time. And the Accutide will not give you this result and raise the eyebrow to the position that you want to, and then remain stable for all the months that you want to. That is something that's not going to happen, and could be disappointing if you are expecting for that. So look for a woman, like a 40-year-old woman with not very fatty eyelids, not very fatty eyebrows, with a not very low position of the brow, and then start with that. That could be a good patient for that.
Brilliant. Thank you. One more question. Can you use Accutide and Morpheus 8 on the forehead rather than the upper lid to elevate the eyebrows?
You can do it as well. You can do it as well, but it's the point here, the issue here is that there's always the same. Depending on the kind of the patient, you can. That's a good idea. You treating the forehead and with the Accutide and with Morpheus can give you an extra point to raise the brows. Sure, for sure you can achieve an improvement with that philosophy or with that option. But the kind of improvement you're going to achieve will depend absolutely of the kind of the patient, on the select of the ideal candidate. One more time, if you are trying to improve, and some patients that I have shown you before, like with the fatty eyelids or with the heavy upper eyelids, the change will be very, very mild and will probably give you some disappointing result. So that's a good point. That's a good option. That's something that can work in some patients.
Excellent. Thank you, Doctor. So we're just waiting for more questions to come through, but yeah, it seems that there are no more questions for time being. So let's wait a couple of minutes. Is there any more questions from the audience?
You have my
No, I don't
email
think so.
here in this last slide. You have my email in here, so please do not hesitate to text me or send me a message. I will be happy to answer you if I know. I can give you my opinion.
Great. So thank you very much for your crystal clear lecture, Dr. Genoll. So I think we are done.
Okay, thank you very much. Hope you are all doing well, and please stay home, all right?
Yes.
All right, thank you.
Thank you,
Thank
doctor.
you.
And thank you to the audience.
Bye.
Bye.
Today, Mo team. Thank you.
Yes,
Bye.
thank you. Bye.
Take care. Bye. So.
Right.